We're very pleased to have another academic geriatrician speaking to us now. So here we've got Anita Nitchingham, who's an academic geriatrician at the Prince of Wales Hospital and Vice President of the Australasian Delirium Association. And she's recently submitted her PhD thesis, which is fantastic, in 2025, which was about cerebral glucose metabolism and intranasal insulin for the treatment of delirium. So the title of Anita's presentation is Not Just Confusion, Delirium as a Falls Prevention Target. Welcome, Dr. Nitchingham.
Thank you. I changed my title, but they're both relevant. I want to thank Steve Lord for inviting me and Stephen Fu for organising today so smoothly and getting all of us in order. Let's get cracking. So I'm going to talk today about the relationship between delirium and falls, which I'm sure a lot of you are across. And I thought I'd start with two cases. They're not like grand rounds, crazy cases. They're just run-of-the-mill cases that you'll probably see on the wards all the time, but they really bring back to how interrelated these conditions are. So this is an 85-year-old male who presents with confusion and reduced oral intake and reduced mobility to the emergency department. He has a background of moderate dementia. He's also frail with mild visual impairment and mobilises with a four-wheel walker. He needs assistance for showering. He toilets himself independently and his son helps him with all of his ADLs. The ED does a collateral history and a 4AT and they diagnose him with delirium and find that it's secondary to a urinary tract infection and acute kidney injury, so urosepsis. And he's transferred from the ED under geriatrics to the cardiothoracic wards because there's no beds in geriatrics. And when I did my ward round this week, we had 22 patients over 10 wards. So these problems are problems throughout our hospital at the moment that we all need to be across. They were treated for a UTI and AKI, and then he became agitated overnight. And in the notes, he had a clinical review for his agitation. It was really thoroughly worked up, but ultimately he needed some antipsychotics because despite everybody's best efforts, they weren't able to keep him safe on the ward. And then later there was a loud noise and he was found on the floor and they investigated him and found that he sustained a proximal humerus fracture. He needed some analgesia, which made him more delirious and constipated. And over time, they hoped that his delirium would get better, but he was unable to participate in rehab, and ultimately he was discharged to respite, which really is probably going to be permanent care for him because when he's in respite, he's unlikely to mobilise, he's going to lose a lot of muscle mass, maybe he might have persistent delirium, and he's likely to be in long-term care. So here's a tipping point. This gentleman was managing okay at home, comes into hospital, becomes acutely unwell, and ultimately needs to go to a nursing home afterwards. This is a slightly different case. A 90-year-old female, home alone, presents with a fall on the sidewalk after trying to put the bins out. It's always the bins or the cockroaches. And she has a background of just mild cognitive impairment. She's mildly frail. She's got a four-wheel walker to walk. She's got a level 2 home care package. Of course, she's on the wait list for a higher package. She's unable to walk and reports hip pain and is brought into ambulance, put on a hip pathway. At triage, she's alert and orientated. She's given some analgesia. She has an X-ray which demonstrates a hip fracture. She's seen by orthogeriatrics very quickly who find that she's delirious by the time they go to see her, so she's scored 10 out of 12 on a 4AT. She undergoes surgery for a hip fracture. She has ongoing delirium postoperatively, but she actually gets better, and she goes to rehab and she's discharged home on a TACP. Okay, so just wanted to describe that delirium and falls have a bidirectional relationship, and certainly in the hospital, delirium is a primary driver of in-hospital falls, but out of the hospital, falls can lead to delirium and in hospital as well, and we'll talk about that relationship. But some commonality and some differences, so the prevalence of delirium is much, much higher than falls. So in people that are aged over 65, about 25% of people will have delirium at some point during their hospital admission, so 1 in 4, very, very high. Falls is much, much less, it's about 1 to 2%. In hospital older patients. There's a lot of overlap, but delirium is a primary driver of falls in hospital, and the visibility is very different. So falls, very hard to miss. Someone will be on the ground, they'll say they've fallen, they've injured themselves. Delirium, still missed very, very commonly. I think we're getting much, much better at identifying delirium, but I still think a huge amount of delirium is missed. And in terms of the outcomes, so this is actually a US study, but I think it's relevant to Australia. This is based on coded data of people that had delirium and didn't have delirium and experienced a fall. So you can see here that people that didn't have delirium and didn't have a fall, which is on the left, had a length of stay of 4 days. People that didn't have delirium but had a fall had a length of stay of 8 days. People that that had delirium but no fall had a length of stay of 9 days, so sort of comparable. But then people that had a delirium and a fall had a length of stay of 22 days, so it's more than double. And we see the same for discharge to residential aged care facility, except if you have a delirium, you're more likely to go to residential aged care than if you have a fall. And this is an audit that was published, and I'm sure many people in this room have been asked to audit their falls in hospital. But what this is showing us, and it's a little bit old now, but I think it's still relevant, it's that it's the number of falls versus... so what they did was they looked at who was diagnosed with delirium, and then they did a chart review to see who had delirium based on what the nurses or the doctors was writing in the chart, but it wasn't necessarily diagnosed. So you can see there on the left that the blue is no injuries from the fall and the green is injuries from the fall. That, of course, people that had a diagnosis of delirium were falling, and people that didn't have a diagnosis of delirium were also falling, but a lot of those people had evidence of delirium. So the delirium was undiagnosed. And so if somebody has a fall in hospital, there's really strong evidence that we really need to start thinking about delirium. And it should be automatically triggered in those pathways, and I know those pathways are starting to exist now. But if we don't diagnose the delirium, then we don't go on to investigate possible medical causes or precipitants of delirium, and the delirium is going to be untreated. So I think most people would know what delirium is, but the key here is it's a clinical diagnosis. It's a sudden onset. This is the DSM-5 criteria, kind of like gold standard. It's acute and it fluctuates, and I think the fluctuating nature of delirium makes it particularly hard in hospital because the medical team will go in the morning and they'll be fine, and then at 2 a.m. they're a completely different person, and that can change their risk assessment. So within a 24-hour period, there's a disturbance in other cognitive ability, so that might be visuospatial, it might be perception, all of your different cognitive domains. It's not due to dementia, but dementia is a major risk factor. And it's due to an underlying medical condition. And usually people have multiple reasons for becoming delirious, and I'll show you that in a minute. So in terms of the types, there's hyperactive type. This is the least common, but the most obvious, so you can't miss it. And so these people actually have the best outcomes because they're showing themselves to be delirious and causing a lot of increased use of healthcare time on the wards. The hypoactive delirium is far, far more common, but it often gets missed, and it's associated with the worst outcomes. So, you're lying in bed, you're not eating and drinking, you're not moving, you're going to have worse outcomes. And I think about myself doing a round as an intern on my surgical ward, and we just said everyone was sleeping, like we didn't wake anyone up. And in hindsight, we were probably missing a lot of hypoactive delirium. So we're much better at that now, but there's still a long way to go. And obviously there's mixed delirium. And there are no biomarkers. I can't do a blood test, can't do a CT to diagnose delirium. But how do I describe delirium to patients? I would describe it as acute brain failure. I think it is just organ failure of the brain. So when we conceptualise acute heart failure, patients get it. When we talk about acute kidney injury, patients get it. I think delirium is best described as acute brain failure to patients because I think delirium doesn't sound like a medical condition to a lot of lay people. And because you have acute brain failure, you can present in a variety of different ways, and certainly these are the things at triage that make me start thinking about delirium, and I use a different one for falls because we're at a falls thing. So this is my PhD supervisor, Gideon Kaplan. He describes delirium as a linchpin condition, which I think is a beautiful analogy. So the linchpin is the pin that holds the wheel in place. So if the pin falls out, the wheel falls off and the car crashes, and I think we see this quite commonly in delirium. So I can't do a talk about delirium without looking at Sharon Inouye's work, and whenever I see somebody with delirium, this is the picture that's in my head, and it's describing why people become delirious. So delirium results from this interaction between your predisposing risk factors and then exposure to a noxious precipitant. So why do we see it so much in geriatrics? We see it so much in geriatrics because there's an accumulation of risk factors. Some of our patients have all of those risk factors: dementia, cognitive impairment, functional impairment, visual impairment, etc., and they need a very small noxious insult to become delirious. So yes, maybe an asymptomatic UTI could cause their delirium, maybe constipation could cause delirium. On the other hand, if you don't have an accumulation of those risk factors and all you have is maybe age, and they're presenting to the ED with delirium, and you're saying that they're delirious secondary to some white cells in their urine, I would argue that you need to look much, much deeper to see if you're missing something else that's causing that delirium. And that's why people in the intensive care who are critically unwell but don't have any of those risk factors also have a very, very high rate of delirium. So I don't have any of those risk factors except for visual impairment because I'm wearing some contact lenses. But if I was in the ICU with sepsis and multi-organ failure on lots of centrally acting medications for sedation, I would also be delirious. Just to be clear, that the point prevalence of delirium in the hospital is about 15%. So if you do a 4AT and everybody in your hospital aged over 18, about 15% will be delirious. So very, very common. So what are the outcomes? Well, a lot of you would be aware that your HACs and other outcomes are much higher if you are having a delirium, which makes sense. We've spoken about that. But I just want to talk a little bit about the relationship between delirium and dementia. So we know that dementia is a big risk factor for delirium, and delirium is a big risk factor for future dementia, but there's more and more evidence coming out to suggest that there's kind of the delirium itself may be contributing to future cognitive decline. And we don't have really firm evidence of that yet, but certainly there's a lot of work going into that field. So it looks like there's a relationship between the actual delirium itself and the development of dementia. And of course, if you have dementia, Alzheimer's disease, and you get delirium, then it accelerates your cognitive decline. And this leads to all of the things that, leads to all of the things that you don't want when you get older, and it costs the government a lot of money. So this is a graph, or whatever it is, made by someone who is mentally not that well. And this was me on my maternity leave. Some people thrive on maternity leave. I question whether I was thriving on maternity leave. But what I was trying to do was to talk about, I wouldn't take a photo of this, but it's the relationship between delirium and dementia, both on a pathophysiological level and a clinical perspective, and how it's really hard to tease out, is what I'm seeing on if I'm trying to investigate the underlying causes of delirium in terms of thinking about therapeutic targets and pathophysiology, it's really hard to tease out what's delirium, what's dementia, what's undiagnosed dementia, etc. And there's a lot of commonality there. But if we just block out that mess in the middle, it's showing us that delirium and dementia share many risk factors, that the more delirium you have, the worse the delirium in terms of severity, the more episodes, the more likely you are to get dementia. And then, of course, dementia will increase the likelihood of you having a precipitant for delirium, whether it's a fall or malnutrition or aspiration pneumonia, etc. And so I was inspired by myself, and I did one for delirium and falls. This is a very clinical perspective, but just to say that they have many, many shared risk factors, and that the delirium itself will increase the risk of you having a fall, because delirium leads to inattention, impulsivity, impaired judgment, all the things that will increase the risk of you having a fall. You will also get kind of indirect increased risk of having a fall because you will eat less, so you'll be dehydrated and you'll be hypotensive, and that will increase the risk of you having a fall. You won't walk and your muscles will atrophy, and that will increase the risk of you having a fall. And of course, maybe the CNS active meds, which Sarah's already spoken about. And then, of course, falls can increase the risk of delirium, which we've discussed. And just to say that motor disturbances are common in delirium. So this is a study which looked at the HUBAM, which is a hierarchical assessment of balance and mobility. The higher your score, the worse your balance and mobility, and the lower your score, the better. And what you're seeing on the left there is that fine dotted line at the top is delirium, and the other dotted line on the bottom is people that are admitted to hospital. So it's showing us if you're sick in hospital, you're going to have impaired mobility, but it's much, much worse if you have a delirium. And similarly, you can see on the write their people's trajectories from the crosses when they have delirium to the dots when the delirium's resolved. So what can we do to reduce the risk of falls in hospital? As a deliriumologist, we should really focus on preventing and proactively managing delirium. And we've heard from Bronnie and Sarah about multi-component interventions, and again, I will touch on them briefly, but the plan is we can prevent delirium and we can stop the complications from delirium. So there is no argument at all that multi-component interventions will reduce hospital-acquired delirium by about 40%. And you may think this is very old data and might not be relevant now, but we can look to Queensland, where Alison Mudge published the CHERISH study in the JAMA Internal Medicine, and they essentially took a multi-component intervention only maybe 5 or 6 years ago, and they did Eat, Walk, Engage was their intervention, and they still reduced the rate of in-hospital delirium by 40%. So it's still relevant even now. And I think you're all across multi-component interventions. I found this one on the internet, which I thought was great. You can see sensory impairment, cognitive stimulation, fluid nutrition, simple communication, mobilising people, sleep promotion, medication review, and pain control. Geriatrician here, don't forget bladder and bowels, I had to add that on. And when I looked at the multi-component interventions for falls, just like Sarah did for medications, there's so much overlap here. So, as a consequence, it's not surprising that when you look at trials that tried to reduce the rate of delirium, they also reduce the rate of falls. And I think some of that is indirectly from, just addressing these high-risk people that are high risk for falls and delirium and reducing their risk, and also directly from reducing delirium burden on the wards. And so, yes, they show, again, a 40% reduction in falls. How do we treat delirium? Well, at the moment, the treatment is much the same. So again, multi-component interventions. But when somebody develops delirium, we need to be very proactive about reducing their other hospital risks. So thinking about pressure area care as soon as someone's has a delirium, and reassessing their falls risk. But again, I think Bronnie really beautifully mentioned that tension between autonomy and just reducing risks and trying to make our data look good, and I think that is a really challenging space. I suppose the way that I would approach that is when I see a patient on the ward and I'm speaking to their family and I'm talking about delirium, as part of explaining what delirium is, I say, unfortunately, they're going to be at a high risk for having a fall in hospital. We're going to do what we can to reduce that risk, but we want to make sure that we're also mobilising them too. And just preparing the family for the fact that that's a reality of having delirium in hospital, and that we can, and then, as you've said so beautifully, seeing what's most important for that patient and for that family at the time. Are there any drug treatments for delirium? The answer to that is no. Antipsychotics are used off-label, so we're taking some risks. They're not on the PBS for delirium, but we do use them for managing distress and for chemical restraint. There's no evidence that they improve outcomes in people with delirium. There's probably evidence they make it worse. So, and they also independently increase the risk of having a fall. So use the lowest effective dose for the shortest time when you absolutely need, and that's it. Are there any other drugs on the horizon for the delirium? So this is an area that I'm sort of interested in, unfortunately, Sarah, who would not be interested in adding more drugs for delirium. But, delirium's really, really complicated. We've spoken about older people with delirium, younger people with delirium, post-operative delirium, infectious delirium. There's so many different types. Are they all the same? Is targeting one pathway going to help everybody with delirium? Probably not. At the Prince of Wales Hospital, we're interested in metabolism and the way the brain is using glucose during an episode of delirium. And there is evidence in older people that you can see this is a PET scan. So this is a scan where we give people glucose and we see how parts of their brain take up the glucose. And you can see there on the top, it's somebody during an episode of delirium, and the brain looks much more purple. And then after the delirium resolves, the brain looks much more yellow, so there's increased glucose uptake into the brain. So this is an area that we're quite interested in terms of determining whether there's anything we can do about it. So as part of my PhD, which is done, we wanted to determine whether intranasal insulin could help people with delirium. So we gave them intranasal insulin, so insulin snorted up into the nose. There's evidence that it's taken up into the brain. And within the brain, insulin seems to have really important roles in terms of neuromodulation. So it targets lots of pathways affected in delirium. That includes neuroinflammation, the way brain regions talk to each other, and your reactions to stress. So we gave almost 50 people insulin in their nose, and we gave almost 50 people control in their nose, and we measured how long their delirium lasted when they were admitted to hospital. And we found that people that got the intranasal insulin had a median duration of delirium of 4.8 days, and people in the control had 6.8 days, but it wasn't statistically significant. When we did a subgroup analysis by age, so the average age of people in this trial was 88, which is exceptionally older. We found that there was a significant difference in the younger group, where the average duration of delirium for intranasal insulin was 4 versus 7 in people that didn't receive it, but there was no difference whatsoever in older people. And we found that the length of stay was substantially reduced in the intranasal insulin group, so it was almost 13 versus almost 8. But this is a small single-centre trial, and now there's lots of trials going on the prevention of delirium using intranasal insulin. And I think this is an example of one targeted pathway that might be able to help people with delirium, but we need bigger studies. And there's lots of people looking at different pathways, whether that's sleep pathways, pain pathways, inflammatory pathways. And so I think over the next 10 years, there might be some more options. Just very briefly, while I finish, I wanted to talk about what happens after somebody's discharged with delirium. We know that about 30% of older people admitted to hospital with delirium will still have symptoms of delirium when they're discharged. And this is a systematic review looking at delirium and falls in the community. And it found that there was very few studies looking at this, but the studies do show that an episode of delirium in hospital increases the risk of you having a fall, and falls increase the risk of you having delirium. But most of the studies aren't adjusting for really important factors like dementia, frailty, comorbidity. So I will almost finish on this slide. This is a slide from Giuseppe Bellelli. He's from Italy. I love the title of this. It's Frailty, Delirium, Vicious Cycle. And I like it because I've never heard frailty and vicious in the same sentence, but I think it's true. So you can see there that less frailty, when you have an acute stressor, maybe a hospital admission, you recover quite quickly. Whilst if you have severe frailty and maybe some delirium when you're admitted to hospital, you don't quite get back to where you were before and you dramatically decrease. So I guess the question is, when we're discharging people from hospital, is there something that we could do? Should we be a bit more proactive about educating people about frailty and dementia prevention and things like that, and what they can do from a lifestyle perspective to improve their outcomes? And this is an area of research a few people are looking into at the moment. So, my take-home messages are, it's frozen, there we go. Delirium's acute brain failure, it's still often missed, so keep looking for delirium. If you've got a low rate of delirium at your hospital, I don't think it's something to necessarily be proud of. When an older inpatient falls, you must think of delirium. When an older inpatient has delirium, you must think of falls, you must think of them as almost the same entity in hospital. They have to trigger off each other, and I would argue now we should also be adding medications and all the other things to that list. To prevent delirium, we can also prevent falls, and they're markers of frailty, and we need to start thinking beyond discharge. And I would just like to acknowledge all my collaborators, the Australasian Delirium Association, just to put a shout out that we do some great events, and if you're interested, we're having a big conference in Melbourne next year in October, and that I'm part of a steering committee looking at what should delirium research priorities be. So if you'd like to fill in a survey about what you think we should be researching in delirium, it's for consumers and clinicians, then there's a QR code there, or you can go to the Australasian Delirium Association for more information. Thank you.
Thank you so much, Dr. Nitchingham. That was really, really useful and so practical as well. I think we might move on because I know that morning tea is a really crucial part of this this yearly event. But we'd just like to again have Dr. Fu give you a small gift and a certificate. And photo opportunity. Excellent. Thank you. Thank you.